Good morning, everyone. Today we're diving into a fundamental tool in clinical practice, the Comprehensive Metabolic Panel, better known as the CMP. Think of the CMP as a multifaceted snapshot of your patient's blood chemistry. It provides crucial insights into three key areas. First, it gives us a glimpse into the body's energy utilization. How effectively is the body processing sugars and fuels? Second, it offers a quick check on the functional status of the liver and kidneys, those workhorses of metabolism and waste elimination. Now, let's get down to specifics. What does the CMP actually measure? The CMP is often part of a routine health evaluation. It casts a wide net, assessing several crucial areas. This includes analyzing glucose levels, calcium balance, protein synthesis, electrolyte concentrations, and the function of the liver and kidneys. Now, I know what some of you might be thinking. Where is the thyroid? After all, this is a metabolic panel. It's important to remember that the CMP focuses on key metabolic pathways, and while thyroid function is critical, it's typically assessed with a separate panel. Keep in mind that reference ranges for these tests can vary slightly between different laboratories. Factors like measurement techniques and specimen handling can influence these ranges. Always refer to the provided reference ranges on your patient's lab report for accurate interpretation. Before we delve into individual components, let's look at the bigger picture. Keep in mind that we'll have dedicated lectures for most of these analytes, exploring specific conditions and clinical presentations in greater depth. To clarify the differences between commonly ordered metabolic panels, this table outlines the components of various chemistry panels. As you can see, the CMP, represented here by CPT code 80053, encompasses a broader range of analytes compared to the basic metabolic panel, or BMP, indicated by code 80048. Note the overlaps and the unique additions that provide a more comprehensive metabolic picture. Let's simplify this further by directly comparing the basic metabolic panel, or BMP, to the comprehensive metabolic panel. While both panels offer valuable information, the CMP stands out by incorporating key liver function tests. This allows for a more holistic evaluation of a patient's metabolic status beyond the basic functions covered by the BMP. And what about the cost difference? You'll be happy to know that the additional insights provided by the CMP come at a relatively small cost increment. Now, let's break down the individual components, starting with glucose. Elevated glucose levels, particularly in a fasting state, often point towards diabetes. It's crucial to follow up on abnormal results with confirmatory diabetic testing. However, remember that other factors can temporarily elevate glucose levels, including a recent meal, acute stress from events like a myocardial infarction or stroke, endocrine disorders such as hyperthyroidism, and even certain medications like corticosteroids. A thorough patient history will help you determine the appropriate follow-up steps. Speaking of glucose, let's refresh our memory on the specific glucose level indications. As a reminder, normal fasting blood glucose falls between 70 to 99 milligrams per deciliter. Prediabetes, or impaired fasting glucose, ranges from 100 to 125 milligrams per deciliter. And a diagnosis of diabetes is confirmed with two separate fasting glucose readings of 126 milligrams per deciliter or higher. Moving on from carbohydrates, let's examine the protein components of the CMP, namely total protein and albumin. These values provide insight into your patient's nutritional status and can signal liver dysfunction or other systemic issues. Focusing on serum proteins, let's consider factors that can cause fluctuations in total protein levels. A decrease may occur with reduced production of albumin or globulin, such as in malnutrition, cancer, or severe liver disease. Increased protein breakdown or loss, as seen in kidney diseases like nephrotic syndrome, can also lower these levels. Finally, conditions that expand plasma volume, like congestive heart failure, can dilute protein concentration. Conversely, an increase in total protein might indicate increased production, often seen in inflammatory disorders or multiple myeloma, or a decrease in plasma volume, such as with dehydration. Next up is calcium, a key player in numerous physiological processes. Elevated calcium, or hypercalcemia, can be a red flag for conditions causing excessive bone turnover, like certain cancers or hyperparathyroidism. In these cases, ionized calcium, or ICA, is a more sensitive marker for parathyroid dysfunction than total calcium, or TCA. On the other hand, low calcium, or hypocalcemia, might indicate liver disease, as a significant portion of calcium is bound to albumin. Malnutrition, whether from starvation, eating disorders, or malabsorption, can also lead to hypocalcemia. Follow-up testing, including both total and ionized calcium levels, is crucial for pinpointing the underlying cause. Now, shifting our focus to electrolytes, the CMP provides insights into sodium, potassium, chloride, and bicarbonate, often reported as carbon dioxide or CO2. These electrolytes are crucial for maintaining fluid balance, nerve function, and muscle contractions, among other vital roles. Let's start with sodium. First, hyponatremia, or low sodium, can be attributed to several factors: decreased sodium intake, increased sodium losses, increased fluid intake or retention, and decreased body water loss. Delving deeper into hyponatremia, it's crucial to understand that it reflects an excess of total body water relative to sodium content. An absolute loss of sodium can result from low intake coupled with ongoing urinary excretion, excessive sweating, vomiting, diarrhea, diuretic use, conditions like Addison's disease, increased urine production seen in diabetes, and various forms of acidosis. On the other hand, a relative decrease in blood sodium can occur from imbalances in other body fluid compartments or increased total body water. This is often observed in edema, congestive heart failure, liver failure, kidney failure, excessive water intake, or consumption of only hypotonic fluids. At the cellular level, hyponatremia leads to water influx due to osmotic pressure, potentially causing cellular swelling. This can impact red blood cell function and lead to dangerous brain swelling, underscoring the need for prompt recognition and management. On the flip side, hypernatremia, or elevated sodium, indicates a decrease in total body water relative to sodium content. This can arise from impaired thirst mechanisms, limited access to fluids, and dehydration. Increased sodium intake, usually dietary, also contributes to hypernatremia. Decreased sodium loss, often associated with Cushing's syndrome, where elevated cortisol leads to sodium retention and potassium loss, can also elevate sodium levels. Lastly, increased body water loss from reduced antidiuretic hormone ADH activity, as seen in profuse sweating, can result in hypernatremia. Moving on to another crucial electrolyte, potassium. Hypokalemia, or low potassium, often stems from reduced potassium intake or excessive losses, either through the kidneys or the GI tract. Absolute potassium loss can be attributed to insufficient intake, vomiting, diarrhea, or renal loss, often driven by increased aldosterone activity. A relative decrease in potassium is observed in insulin-dependent diabetics, as insulin promotes potassium uptake into cells alongside glucose. Conversely, hyperkalemia, or high potassium, is frequently encountered in hospitalized patients, particularly those with severe illnesses requiring medications that can affect potassium levels. A common culprit is the use of ACE inhibitors or ARBs for blood pressure control in patients with underlying kidney disease. These medications can spare potassium, leading to elevated levels. Moving on to chloride, another key player in maintaining the body's delicate balance. Chloride primarily helps regulate acid-base balance in fluid levels and often mirrors sodium level fluctuations. When sodium and chloride are lost or gained proportionally, it often indicates a loss of free water or a gain of electrolyte-rich fluids, respectively. However, a selective loss where chloride is disproportionately gained or lost suggests a metabolic imbalance. For example, an excess of chloride often points towards metabolic acidosis, while a deficiency indicates metabolic alkalosis. Hypochloremia, or low chloride, can result from impaired renal absorption, vomiting, diarrhea, and metabolic acidosis. In contrast, hyperchloremia, or high chloride, can be seen in dehydration, excessive dietary salt intake, congestive heart failure, cystic fibrosis, and other conditions. Interestingly, sweat chloride testing is used in diagnosing cystic fibrosis, with levels typically 2 to 5 times higher than normal in affected individuals. Lastly, for electrolytes, we have bicarbonate, a critical component of the body's buffering system. A low bicarbonate level can occur with Addison's disease, chronic diarrhea, diabetic ketoacidosis, metabolic acidosis, compensated respiratory alkalosis, shock, kidney disease, ethylene glycol or methanol poisoning, salicylate overdose, and severe diarrhea. On the other hand, high bicarbonate can indicate severe, prolonged vomiting, lung diseases like COPD, Cushing syndrome, and metabolic alkalosis. To visualize the relationship between pH and bicarbonate/CO2 levels, refer to this diagram. It illustrates the primary compensation mechanisms in acid-base imbalances, highlighting the interplay between metabolic and respiratory components. Moving beyond electrolytes, the CMP offers insights into kidney function through BUN and creatinine levels. While not included in the CMP itself, the BUN/creatinine ratio and the estimated glomerular filtration rate, or GFR, provide valuable additional information about kidney function. To better understand the clinical significance of BUN/creatinine ratio, let's delve into the detailed physiology. As you can see from this table, the BUN/creatinine ratio can help differentiate between various causes of kidney dysfunction. A ratio greater than 20:1 suggests increased BUN reabsorption, often indicating reduced blood flow to the kidneys, a condition known as prerenal azotemia. This can be caused by heart failure, dehydration, or bleeding, as well as a high-protein diet. A normal ratio, falling between 12:1 and 20:1, points towards normal BUN reabsorption or postrenal causes, where the obstruction lies beyond the kidneys. A low ratio, less than 12:1, typically indicates intrinsic kidney damage, impairing BUN reabsorption. Keep in mind that a decreased ratio can also be seen with liver damage or malnutrition, as the liver is responsible for producing urea. In addition to the kidneys, the CMP provides valuable information about liver function through several key markers: alkaline phosphatase or ALP, alanine aminotransferase or ALT, previously SGPT, aspartate aminotransferase or AST, previously SCIT, and bilirubin. These tests help assess liver health and detect potential abnormalities. While we'll delve deeper into liver function tests in a later lecture, this slide is a placeholder for future reference. Now, let's apply what we've learned by looking at an example of a CMP report. Notice the flagged abnormal values and the corresponding reference ranges. These highlights help clinicians quickly identify values that require further investigation. To simplify interpretation even further, this table organizes the results of the CMP, clearly marking values as in range or out of range based on the provided reference intervals. For a practical application of interpreting individual test results, these slides focus on specific tests within the basic metabolic panel, highlighting abnormal values and providing relevant clinical context for interpretation. For instance, in a patient without known diabetes, a glucose level between 100 and 125 milligrams suggests prediabetes, necessitating confirmatory testing. Similarly, when interpreting creatinine levels, age and ethnicity should be considered, as reference ranges can vary.